All right. Hi, everyone. My name is Sebastian Roy. I'm not supposed to be your moderator today, but our moderator is having technical difficulties, so we're going to kick off this discussion. Thank you to everyone for joining. We're really happy you could be here with us today. The title of our webinar is How Are FHIR-based APIs Changing Healthcare? These series of webinars that the New York HIMSS chapter is organizing are meant to be a somewhat of a replacement of our traditional annual mini HIMSS event that we hold in June of each year. And so thank you for joining the first of our events. The learning objectives of this webinar today are to understand the state of development of open access APIs within healthcare, understand how regulatory requirements affect open access APIs in New York State, and understand the business implications of the availability of open access APIs. We have several esteemed panelists with us today. This will be a free-flowing discussion. And so I think we can start off by letting them introduce themselves. So I forgot to introduce myself. My name is Sebastian Roy. I'm a treasurer of the New York HIMSS chapter. First up on our panel today, we have Lloyd McKenzie from Jevity Consulting. I'll turn it over to Lloyd so he can introduce himself quickly.
Lloyd, you're on mute.
Sorry about that. My name is Lloyd McKenzie. I'm a senior consultant with Jevity. I've been doing FHIR and healthcare interfaces, healthcare interfaces for about 20 years. FHIR since before it was even called FHIR. Spend most of my day job and a lot of volunteer time helping support the FHIR community, and looking forward to sharing a bit about what FHIR does with you.
Great, thank you, Lloyd. Next up, we have Virginia Lorenzini from New York-Presbyterian Hospital. Over to you, Virginia.
Hi, everyone, welcome. Yeah, I work at New York-Presbyterian, where I work on regulatory subject matter expert and standards expert. I've been involved in the HL7 standards community since the 90s, really excited about FHIR and its opportunities. And I'm also on the faculty at Columbia, where I run our FHIR lab and advise on interoperability.
Thanks, Virginia. Next up, we have Helen Oscislawski. Sorry for butchering your name, Helen, if I did. If you could introduce yourself as well.
That was pretty good, actually. So hello, everybody. Thanks for joining us today. I'm pleased to be here and to be invited to among my esteemed panels. I'm an attorney, a healthcare regulatory attorney that's been working in this space for over 20 years. I have a particular niche in data privacy laws, and particularly in the context of health information exchange. So with respect to FHIR, which has only come sort of on my radar within the last year, unlike the other experts and security experts and technical people, I know enough to be dangerous, but hopefully I can bring a perspective of what that's going to mean from a practical and operational perspective from organizations like healthcare systems, hospitals, and even HIE and HIN. So again, pleased to be here.
Thanks, Helen. Next up, we have Mike O'Neill from MedicaSoft.
Thanks, Sebastian. I'm Mike. I'm the CEO of MedicaSoft, and we're a healthcare software company that's been working with FHIR since early days, as you've heard from Lloyd. We've had a native FHIR healthcare data platform doing health information exchange and all payer claims database for 5 or 6 years in production. We built a number of user-facing, both provider and patient-facing applications on FHIR API as well. We've also lent some FHIR expertise to the Department of Veterans Affairs and helped them build a FHIR API that supports their mobile health applications as well. So I look forward to the discussion.
All right, thanks, Mike. Hi, we'll just pause here because it looks like we may have some news about our moderator. Sushil, were you able to get our moderator on?
Yes, if you can hear me.
Oh, is that Tom?
It is.
All right.
Well, I deeply apologize. I don't know what happened here, but that doesn't matter.
All
we'll
right.
move on from here.
Sorry, Tom, just give me a sec. Jamie, if you could share Sushil's video stream instead of the slides so we can see the moderator at this point. Tom, just to catch you up, the panel's given their introductions. We were getting just to yourself, so you got here just in the nick of time if you want to give a brief introduction on yourself, and then we can jump into the use cases.
Great. All right. Well, thank you. And thanks for jumping ahead with the introduction while I scrambled around and finally managed to get myself on here. So as noted, I'm Tom Hallisey with Haney's, the Healthcare Association of New York State. I've been in health IT for longer than I'll count, starting way back at Meditech and eventually leading to roughly 20 years as a health system CIO in New York and Washington, D.C. And I know since we're on video, you're thinking, boy, you must have started Meditech at 10. And yes, I did. So you've already heard what a great panel we have today that we'll be looking at some scenarios and answering all your questions. I'm not sure if we did some housekeeping, but you can ask questions. Did you go over that?
No, go ahead and explain it.
Yeah, sure. So at any point, you can jump into the chat and ask your questions, and we will be trying to get to all of those as we move forward. We've got a few scenarios teed up that we'll start with, and then we'll try to get to all of those questions as we move forward. And before I was even going to jump into that, I just wanted to give a 2-minute review of why we're discussing the FHIR API, why now, where it's going, kind of the what, why, where of the FHIR API. We certainly assume you're on this, so you're aware of what the Fast Healthcare Interoperability Resources API at least is and intends to do. But some of the key points about this API are that it's standard-based for a very quick implementation. The standards based on are web-based standards. That's free for use. There are many examples already available, and you can get some interop running right out of the box. But it's also quite expandable. And so why now? Of course, as we all know, interoperability, at least in real time, for patient access, for clinical care within your workflow, and for population health is in desperate need of this type of tool. And on top of that, right now, of course, we're all aware, ONC and CMS have said this is a requirement for all, as they put it, actors. And so all actors must have the capability to use the standard FHIR API and must allow any application that the patient chooses to connect via that FHIR API. That regulation has come out. We haven't hit the deadline times yet, but the actors involved are providers, health systems, health information exchanges, EMR vendors, and even now the latest, the payers. So really you can get at all of your data across that spectrum. And so where this can lead, well, that's what we'll get into today quite a bit. Suffice to say that CMS and ONC have gone as far as to say this is similar to the creation of a smartphone, and that we can't even necessarily guess at all the apps and the changes in healthcare that may come about as this FHIR API with the new regulations rolls out into our world. So enough with the hype and the technical glitches, I certainly hope. And let's jump into hearing from our panel on the first scenario we've teed up, where we can hear from all the great perspectives we have on the panel on a topic we wanted to start with, which was in this pandemic crisis. Let's look at a potential app using the FHIR API as an assessment tool many of which we've already seen during this crisis, but now with the ability to pull data directly from all of your health systems, from your payer to get your claims, do this in real time as you needed, and interact that data with the assessment, and if we chose, also data on your phone, to provide a great resource, certainly, on who needs further care and how we should treat these folks at home. So with that said, that's our first scenario we're going to look at and get everyone's perspective. And I think we'll begin with Lloyd, who you've already heard his wonderful background.
All right. I mean, the notion of standing up an app that you didn't even realize that you needed is certainly one of the areas that FHIR excels at, or having an API in general excels at. When you have an API, it means that you've got endpoints that share patients' conditions, vital signs, all of that other information in a standardized way. And then you can leverage that information in new solutions, and you don't have to create a new custom data interface that is solution specific. You can draw on the existing interfaces that already exist. FHIR brings something additional to the table for this kind of a scenario, a solution called Smart on FHIR that actually lets you embed apps directly into EHRs and also to make them available to patients. And you can give those applications permission to access information from the EHR and from other places in much the same way as your cell phones now. You run an app and it says, I'd like permission to access your contacts, or I want permission to access your microphone, and you can choose to say yes or no. With a Smart on FHIR app, you can say, I want permission to access vital signs, or I want permission to access labs or vitals, and then leverage that information. And because the app is not actually created by the EHR vendor, but instead runs as software that plugs into the EHR, you're not sitting and waiting for a brand new release of software to add this new capability. You can basically have a couple of grad students or whatever in your basement develop a FHIR app and roll it out in your environment in a week or less if you really want to. And even better, the apps that you create can run in multiple different EHR platforms. And so that creates a significant change in the ecosystem in terms of responsiveness to new requirements. And furthermore, once you get the app out there, if you find that, you know what, there's 2 more questions we need to ask, you're not looking at months-long development cycle to go and change the software. You can release it much more quickly. And so you can be responsive to the needs and the feedback that you're getting from your end users, and still leveraging that back end that you built perhaps for other purposes for something that you didn't even realize you were going to need.
Great, thank you. Would anyone else like to chime in on this topic?
I would, Tom, if it's okay, because my view tends towards the technical side as a software company, and maybe picking up on a few things that Lloyd mentioned. You know, when we say things like, well, you can have a couple of grad students put together an app and get it up and running quickly. You know, sometimes we say that kind of jokingly, or we mean it's, you know, easy. There's an aspect of FHIR that has a standard. FHIR was built with developers in mind, implementation in mind, which I would say it's safe to say not all standards are created with the idea that somebody actually has to build these things, right? And so they can be really complicated, and that slows down the time to getting something built and to market. And in a pandemic situation, that's the last thing that you want. So one thing that I think FHIR is already demonstrating is by having as an early objective that this is a standard that's created so people can develop applications of all types rapidly. We're seeing that. So it's not that hard to figure out what are all the arcane details of the data model. Do I need to go get a PhD in data science before I can even start my mobile app? We've kind of eliminated a lot of that. And that's proven to be really helpful for, as a standard rolls out, there are certain events that can push it forward or hold it back. And ease of development, I think, is one with FHIR that is helps push it forward camp. I think that's, I was chuckling when Lloyd mentioned the grad student thing, but actually there's an aspect of FHIR as a standard that really promotes rapid development and deployment of applications.
Great, thank you. Virginia, do you have any comments on a potential app such as this?
So back in caveman days, before FHIR was invented, if you wanted to do interoperability, like you wanted to come into a big organization and create an innovation, whether you're external or you're within the organization. I mean, you could be, a med student who has an idea, right? Or faculty. It's very hard to build it. You might have to try and tap onto an HL7 version 2 interface and get that data. You have to get beyond, the firewalls and work out all of the security. It is a huge stack that you have to climb for you to be able to get any piece of data moving. But the idea that there's just this API that you can just connect to, a published API, it's transformative. And often when we talk about FHIR, we use as an example how APIs have transformed the industry, other RESTful APIs, right? Like Google Maps, thanks to Google Maps, we now don't take taxis anymore, and my kids refuse to drive to McDonald's because Uber Eats can deliver it, so the world has really changed. So it's really exciting. And the other thing that's really exciting about it is, EHRs are great and vendor software products are great. They offer great functionality, right? But there's limits to their functionality. And we're often innovating at those edges. So how can we, one, test those innovations or have a chance to build on those innovations? I would hope that clinicians would be able to have smart tools that really work for them in their workflow. And FHIR allows us to do that, because you could have an app that, maybe works with a bunch of different EHRs, that this doctor likes, that can sit on top, can drink from the FHIR server, from the EHR, but can also be right in the workflow where it's needed and can offer that clinical decision support when it's needed. This is the dream we all have, right, in health IT and informatics, is that we actually help the clinicians and not burden them. So I think FHIR could get us there.
Absolutely. And then, of course, we have our legal expert. Any thoughts to get us started?
Yeah, so I'll react for the people on the phone, on the line today who are. I just learned a lot in 10 minutes. That's and I want to actually react to some of the things that were said and then offer sort of my, step back and the questions that organizations are going to be asking. So let me start with that. So, the first question. First of all, I agree with everything. I think that theoretically, and the whole concept of this in terms of enabling, my husband happens to be a physician, he's an emergency room physician, so access to data is critical, in particular, to Virginia's point, to work it into the workflow process. But from an organizational standpoint, those who have historically invested time in making sure that information isn't released in an inappropriate fashion, the question of the controls are going to be very important. So starting with who is initiating the app and who is controlling the app. And there's a couple of different potential scenarios. So with the first scenario, an app developer, it sounds like they can approach the healthcare system and integrate and create this as part of their ecosystem, their infrastructure that is specific to a large healthcare system. You can see that possibly with like the massive healthcare systems that are nationwide. They will partner with a particular app or vendor and deploy that throughout their ecosystem. And so that app vendor would become a business associate of the healthcare system or the organization. And that sort of a relationship would define what the app developer can and cannot do with that patient data once it is acquiring it in terms of re-releasing it to other third party or reusing it for other potential purposes, whether that's to de-identify, to resell, whatever. So that would be controlled by business associate relationships. The other way you can see the apps obviously coming in is if the patient initially, the patient facing apps. So the patient is actually controlling the app, coming to the system, and through that interface initiating the controls of what you can and cannot see. So with the COVID use case, you know, they could presumably, based on what Lloyd said, the patient can maybe tick something and said, I'm only releasing COVID-related lab data or COVID-related this episode of care on such a date. That's actually phenomenal. If there's that level of granularity and controls that the patient or the provider can select in such a module, I think that's actually phenomenal, because with data exchange at the high level, one of the challenges has been granularity and the inability to control things at a granular level. Again, to react to Lloyd, if you can develop, quickly deploy, and actually this is a question to all you tech people in the ER. I mean, do you envision? So one of the challenges is, do you have to throw the kitchen sink, or can you choose and select what you can release and hold back? And if we can particularly apply that to sensitive information and, you know, say I'm going to release such and such clinical data about me that's general, but hold back my sensitive behavioral health data or my mental health data or the fact that I, you know, have had if we can do that, that's going to further just, I think, accelerate not only the commitment and the comfort level with this data exchange sort of thing, but will just allow it to take off you know, a lot quicker. And then just one last point, and then you can maybe react to my question is the third scenario. So it's the system initiated controls, patient initiated controls, and then we have to deal with third parties. So is it the app developer itself that's asking for this through, like, is it a public health authority that has partnered with an app developer and then connected through the FHIR to systems to pull in COVID data, for example, to go off of our use case, and to pull in that to a third party? And if it is a third party, like a public health authority or a researcher that's outside of the healthcare system, or the originator of the patient data or the custodian of the patient data, then again, who controls the settings of what data they get? So say the public health authority wants the entire medical record, as our use case indicates. Well, you know, they may not be entitled legally to the entire medical record. If they're requiring reporting of just COVID-19 data, then they're only allowed to get COVID-19 data and maybe certain things related to COVID-19 in terms of their public health tracking, but not necessarily all the other stuff. In fact, the standards under HIPAA for public health disclosures is the minimum necessary. So this goes to my legal question of control. So if it's initiated by a third party, who sets those controls? Is it the public health authority? Is it the app developer? Do we always have to get the patient involved there? Or does the system, the healthcare system, the originator of the data, get to control what releases and what releases? So maybe I can punt that out to a reaction, because I don't know the answer to the question from a technological perspective.
I'm not sure I know the answer to that either. I do think you make a great point, though, that one of the major aspects, and I think everyone made this point in some way, new aspects for the FHIR use of the FHIR API versus previous interoperability tools is that they're so easy to stand up and they're so capable of getting to a great detail level that we can look very carefully at sharing only the correct data for the specific use with the correct user. As for the broader question, I'm not sure if anyone feels they have an answer. I'm not sure that.
I can take a stab at it. And the answer, of course, is that it varies. Now
you sound like a lawyer.
FHIR does not make things magically simple, particularly legal stuff, but it does provide a number of tools. So in answer to the who decides, there's decisions at multiple levels. So you can have, obviously the developer identifies what they want and indicates and designs their application to seek certain information based on what they need. These EHRs that choose to allow an app to play, and there is a degree of allowing, choosing what's going to be allowed to run inside your EHR versus not. There's some slightly different rules in terms of what patient apps, so what filters you can put in patient apps, because there's now expectation and regulation that patients can basically do whatever they want. And then finally, there's the user who's actually using the app, who has final determination around, in this particular context, for this particular patient, for what I'm using the application for, is what the application is seeking reasonable or not. And so there's multiple layers. There's questions around what level of granularity should control be granted at. So can you grant access to all vital signs, or can you be more fine-grained and say you can have access to blood pressure but not O2 levels or whatever? And there's trade-offs there, because the more fine-grained you get, the more complex it is for the users to interact with. So there's lots of discussion happening in the community around what the sweet spot is.
Right. I think maybe I might add, if I can, one element there that I think FHIR as a standard offers. You know, there is, as we've said, no magic solution, and the last I checked, FHIR didn't address the legal aspects, you know, directly as part of the standard. But to give you tools, let's just look at something like patient consent, where, you know, for an awful lot of applications and systems today, it's all you can ask to just have a, did this patient opt in or opt out? You know, if you can just deal with that, you're doing pretty well. But that doesn't even approach the kind of granularity that we're talking about here, to say, I do want to share this data, but not that data. I don't want to share sensitive data. Or I do want to share with this provider, but not that one. Or never again with this doctor. You know, all those kind of things happen in real life. And I think FHIR as a standards body spent a fair amount of time on the consent model. So when you get back to the question of implementation, at least in the standard, there's a very, I think, very clean way that you can specify what consent I'm going to support. And once it's defined, let's say, it's a very nice thing to be able to put that in the platform, let's say, behind the API. Now, as an application, I know via this, you know, industry standard API, if I can access that resource, I can see whatever level of granularity this system intended me to have. And if it's none, it's not. But if it's all there, it's a standard way. I don't have to go talk to each health system and say, how is it that you record what a patient said okay to or not?
Right. And I'll tell you that we just had an attendee comment really agreeing and saying a similar argument that Apple Health allows you to push data, was the comment, to the patient portal, but the patient has the ability to select sensitive, non-sensitive data. The app developer can create criteria for the patient, exactly what you had just said, but with a specific example on Apple. I'm going to publish that comment to the group. Thank you all for that. Before I get to more of the questions and comments from the attendees, we had another example scenario that I think is useful for exactly what we were talking about, because there was a lot of discussion just now about the specific use cases. And there's one underway, the HL7 Da Vinci project, which is looking to bring together payers and providers and health systems in sharing data using the HL7 FHIR API. And so we wanted to discuss a little bit about using these new Da Vinci standards and clinical decision support hooks so that clinicians are notified of prior authorization requirements, payer documentation requirements at the time they're ordering a test in real time. So a very specific case, and I like to hear everyone's thoughts on this functionality, where it could go from here, and if you're a part of the project, where it is now.
I'll maybe start out because I'm heavily involved in that project. I'm sort of the technical lead on a couple of the implementation guides that are part of that Da Vinci work. So again, this is an example of basically being able to plug in external applications into an EHR system. So in the previous one, we talked about using Smart to sort of build in a user interface that you can plug into your EHR that does new and cool things. With CDS hooks, you're not building in an interface, but you're building in an ability to talk to an external decision support system. So every EHR has points in its workflow where you're ordering a drug, or you're making a referral, or you're ordering a lab test, or you're making an appointment. You're doing something that's going to drive future action. And there are external systems like payer systems that have useful information that may want to influence what you're doing. So if you're ordering a drug, it's kind of helpful to know at the time that you're ordering it, by the way, there's prior authorization required, and here are the 3 questions that you're going to need to have answered in order to make that prior authorization determination, and hope that's actually kick off the prior authorization process from within that workflow if you want to. Makes things much more efficient. And if a payer is, you're ordering a drug and the payer can say that particular medication is not covered by the patient's plan, this one is, the provider can still make the decision that, you know what, I need this particular med, and the one that's covered is not going to work, and I can have a conversation with the patient about why, so that they aren't having that conversation instead with the pharmacist and then phoning back and making another appointment and trying to figure out what's going on. We can have that conversation now. Or you can say, you know what, this other medication is actually just going to work just as well. We may as well give you the one that's going to be covered, because it's much more likely you're actually going to pay for it and take it if you've got coverage. And so injecting that knowledge into the point of decision making, which APIs enable, because the payer with permission from the system can actually go in and see what lab tests have already been done that might support this particular action, and whether the information necessary for processing a decision support is there or not. And so you can make the whole process much more efficient when the APIs are in place.
You're muted, Tom.
Yeah, Tom, we lost your audio.
Oh, I'm sorry. That was purely my doing, not a technical glitch, I'd like to claim. Thank you. Would anybody else like to chime in on that topic?
I would.
Yes.
Maybe kind of following up on what Lloyd is saying, but you know, there are people that think the U.S. healthcare system could use a little reform, and that we have some inefficiencies in the system. And you know, this is like low-hanging fruit. Payer-provider communication is just a great opportunity to, you know, put interoperability in that space and improve things. You know, a good amount of time is spent in claims denial. How do we resolve claims denial? And one is that's lots of wasted effort, lots of resources, lots of time and money spent on that. But the other thing is it's also takes a toll on human happiness, because I don't know if any of you have gotten really sick and gotten hospitalized, and that was the first horrible experience you had. And the second one is when the bills came that said they weren't paid and you were making all those calls. Imagine if this was taken care of in advance. And our amazing doctors, you know, do amazing work, and they spend a lot of time on the phone with insurance companies and dealing with that. If this could be automated, they could focus on doing the work of taking care of patients. So I'm very excited about that. And the other thing that's important about this is that the payer community is heavily involved in interoperability right now, and the U.S. government has this new regulation that was passed. So this is going to happen, you know. So we can expect this, that in the next few years we're going to see a lot more payer-provider interoperability happening.
Mike, do I see you? You've got some ideas here?
Yeah, thanks. I was going to mention, you know, for sure, there's a lot going on with payer interoperability. In the earlier days of FHIR, a lot of it was focused on clinical data and the provider community, of course, but it's great with the payer community being involved. At some of the final rule, basically the CMS final rule, is discusses how payers now need to make claims information available to patients and actually do a payer-to-payer exchange of clinical data. Well, one of the things that a lot of us hope is, even to stick with the payer authorization example we mentioned earlier, if the idea of an API-based approach and standards-based approach can take hold, maybe that can take hold a little bit more broadly. Where I'm thinking is, Lloyd described CDS hooks as a way to say, within the EHR, when you do an order, hey, let's have some logic that says you're going to need prior authorization for this, and here's the things you're going to need. There's often somewhere in that flow, there's an eligibility check. How does this procedure, let's say, match up with what this patient's plan covers and all of that. If the payer community can start to expose that information via API, let's say, then one step may be you can actually envision a clearinghouse that can do prior authorization, that can say, look, I know what you're asking for, I know what the payer needs, and then I'll gather the medical evidence, let's say, where there may even be a role for other aggregators of data, like state health information exchanges or something like that, and really expedite that whole process. I say that clearinghouse maybe as step one was I think ideally it'd be great to say, well, why do you need the clearinghouse? If everybody has an API and everybody knows the logic and payer can expose information to providers, couldn't we just do that point to point? I don't know, maybe that's too much to ask in one step, but to get to kind of an API-driven approach where FHIR is the API for a lot of this, but maybe not all of it even, really is a great chance to grease the gears on some of this inefficiency.
Well, you make a great point, and that was the next topic we were going to jump into when it comes to the data aggregators. You know, mm-hmm. And I think the scenario we were looking to discuss is you have a consumer app, and all it takes, of course, is one patient saying, I want my data downloaded to my CVS app, as they build one. But it could also be, Uber was a suggested example, that it could be Jenny Craig. There are a lot of options there. But as you pointed out, rather than turning to each and every health system, they go to, in New York, the shiny, and say, we want access. And so, yeah, let's talk a little bit about the security of that. And I think we'll start with Helen as well on the legal implications.
Yeah, so for HIEs and apps, it's interesting. So you're right. I think it is a very efficient way, rather than a certain app going to each of the healthcare systems, which that is happening actually as well. And I guess some of it depends on how this is going to sort of unfold. But you know, aggregators where the app can come in and do a one-stop and say, look, you have this patient's data already from all of the systems, specialists, labs, imaging reports, whatever, it's all here. So it's a one-stop shop, just connect in, and the patient can get all that data at one time. I think that there's an incredible efficiency to that. So some of the questions that come up in that scenario, again, go around controls, scope, and then getting into a little bit of our queue up questions maybe later, is, you know, what happens to that data once the app developer gets it? How do we evaluate who's a trusted partner and who's not? Are there any criteria for sort of vetting that the patient does have control? So the first question is, you know, what does the consent process look like? Is it informed consent? Is it a sort of adhesion consent where it's a click yes, no? Remember that while consent on a general level works for most apps, because we're not talking about health data, when you're talking about certain types of categories of a health data, a yes, no question may not suffice to, for example, for a behavioral health unit to release behavioral health information unless the consent is you know, sufficient and the patient is fully informed. In fact, in the information blocking rule, ONC clarified that educating a patient about the it wasn't risks, but educating the patient about the privacy and security and how apps work, and making sure that the app developer has certain terms and conditions and privacy policies with regard to what they're going to do with that data once they get a hold of it. Because remember, app developers, I'm sure you're all aware, they're not covered entities, and they won't be business associates. So they no longer are subject to HIPAA, or for that matter, any privacy laws, federal or state generally, that generally apply to healthcare information. Now, there is a lot of movement in the FTC, the Federal Trade Commission. There's a push there to have a regulatory oversight, these third-party vendors, to ensure privacy. We see things like state law movement, like the CCPA, that's starting to get after and ensure privacy. So again, the apps and coming in and particularly going after the aggregator and pulling all that data, what is the scope, who sets the scope, who's ensuring that the patient is sufficiently informed about, maybe they don't want their, the fact that they're bipolar going into the app. Maybe they only meant that they wanted to get their last episode of care. So making sure that the patient fully understands the scope of what they're getting on the front end, and then on the back end, what that app developer is going to do with that information once they get it. So that's, I think as a high level, the legal issues up front that, organizations are starting to ask and process through.
Right, and you make a great point there that as a health system or an HIE, as an actor, as you're termed in these regulations, you can educate the consumer on what that particular app looks to be doing with their data. But if the patient insists, we have no choice but to allow them to use that particular app, even if we think what it's doing is highly questionable. And the FTC, to this point, is saying simply that they have to do what they claim they will do in their privacy statement. And and I'm sure you've read plenty of those, you've read those, sometimes it doesn't really tell you much. So, but anybody else have any other thoughts on the HIE type linkage?
I have a thought. I have some thoughts. And also, I just want to, again, clarify that the apps that we're talking about in this use case is one that's patient facing. So certainly if an app was not patient facing, it would be, there would be BAs with the app vendors, just be clear.
Not necessarily, but okay.
Yeah, I mean, in a lot of cases, right? It's really because in theory, patients are using their HIPAA right of access that comes out of it. And then if you mention the FTC and potentially FDA, I think in some cases, if it's a prescribed app.
Biometric, that's biometric.
Yeah, so, and I spend a lot of time thinking about this because, we were required in 2019 as part of the IPPS 2019 rule and another one for outpatient. I think it was PFS. I'm not sure which one. We were required to turn on our APIs for patient-facing apps to release a good amount of important data, including conditions and allergies and medications and labs. So that's pretty important PHI, right? And we have to provide that to all patients, and they're allowed to bring whatever application they want and connect to it. That's what is in that regulation. The newer regulation that just got published in February opens it up and includes more data types, including a really important one, which is clinical notes. Something I wanted to mention is, and I know you know this, Helen, but I just want to bring this out. If I was bipolar, there is the psych notes, and that's a really important thing. And in New York, that's really important to protect. It's my understanding. And then, but it's not just that. I might be on a medication that indicates it. I might go to a particular clinic, and the location might indicate it. There are many different evidence in the EHR that might not be something that someone's flagging. So this whole concept of security tags and tag all the data that might show evidence that someone has something is really technically difficult to do. And then the flip side on how to educate people. So that is a concern of mine. A concern I have with HIEs is if I was a hacker, I'd go for the place that has most of the data, and HIEs are aggregators, and aggregators have a lot of the data. So that's a concern I have. But and I hate arguing multiple points, but I've spent a lot of time making friends with patient advocates. And often patient advocates are people that have gotten really, really sick, and they just want to get all their data together, and they're studying their data. And there's quite a lot out there in terms of research that patients that are activated in their care do better. So it will help our whole healthcare system if patients are activated. So there are people that just want to get their data so they can bring it all when they travel across the country to go to that specialist, and they have such a hard time getting their data. So I really would love to see this, that a patient could aggregate their data and bring it where they want to go. And being able to plug into a network would be so much more efficient than plugging into every EHR. From a healthcare provider perspective, I'd like to say plug into the network and leave us alone. Because it would be less work,
Before we get into more on that, thank you. I noticed we're getting close to 1 o'clock. I think we had more than an hour for some other discussion, but I wanted to jump into some of the questions, and I think they'll fit in with the discussion we were just having here. Certainly one of them was, what is the security risk to the organization with API use? And I think we were just about to get into that with the HIE, and you just noted it. But anybody have any thoughts on that? I want to start us off.
Maybe I can mention a narrow piece of that. The question is very broad. What is the risk? And there's probably better folks on the panel to address the overall risk. But one of the things that we can do using things like the FHIR API, and I think other design patterns like it, to just say API-based, app-based, service-based stuff is. In my own experience at MedicaSoft, we have both a platform that runs some state HIEs and some patient-facing applications that they deploy. So you can never force somebody to actually use the tools, but I think we can do a much better job just in the last few years of giving them the right tools. So even an HIE that would say, I'm following all the rules, I'm doing everything that I can to protect data and even educate a patient, protect their HIPAA privacy and security. It can fall down when you build a great app that has all the right safeguards, platform has all the safeguards, but you don't know that it's actually really the patient that's using that app. Who knows that? So how do you build that in? Well, there's all kinds of ways that you do that. If you're a hospital system, let's say, well, if the patient has registered and is known to my EHR, somebody saw you, right? Because you presented an insurance card or something, and that's proofing. I know that's you, and forever after that, your record is associated with that. An employer, you're in the company directory or something like that, and somebody saw you, and but how do you do that if you're an HIE? Well, once you enter more what I would call, probably Lloyd would call, more modern technology era here with things like APIs, we can do things like knowledge-based authentication. So the app comes in, you sign in, but I'm going to ask you some questions that only you know. I'm sure we've all been through signups like that. There are just more tools that you can use that are not too disruptive to the user, that kind of fit the flow, but really give you an ability to know who's doing this that we didn't have before. And every single thing was custom built, and it was really hard to do.
Great answer. Go ahead.
I'd like to build on that just a bit. So with FHIR, one of the nice things with the technology is that it's built on a technology stack that is used in other industries. So when you're logging into your bank, the little lock that you have on your browser, that same approach to security is leveraged in FHIR, or is leverageable in FHIR. Sometimes you're sharing information in FHIR that is not sensitive, like what are the protocols that we have, and anybody who wants to look at them can see those. It also leverages OAuth. So if you've ever gone to a website and it's prompted you to sign on with your Google ID or with your Facebook ID, and the notion of two-factor authentication, so you fill in the code from your phone to verify that it's you, all of those things come into play. But more importantly, we can draw on that broader community. One of the key things with FHIR is that it's not just a specification, but we've got like 10,000 people who are now signed up to chat.fhir.org, and there's a forum specifically about security where you can go and talk with the experts about what are the best practices and what are the risks, and how do you best manage that. And so being able to tie into that, I mean, obviously, if you're exposing any kind of data over any interface whatsoever, there are risks that you're going to have to mitigate. But if you can leverage best practice technology and you can tie into a community who can advise you on how to best mitigate those risks, you're far further ahead than if you're standing up something yourselves to meet regulatory requirements and are not taking advantage of the standard in doing that.
Great, thank you. There are actually a couple of other questions. I found this one interesting. I thought I'd throw out to the group. Are there competing methods of achieving the same interoperability? I certainly have my opinion, but I'll throw this out to the group. I certainly don't believe that there are methods out there to get the same level of interoperability.
I mean, there's certainly lots of standards that we have had in the past. So, I mean, version 2 is deeply penetrated throughout all of industry, but it doesn't really give you an API. We commonly say that if you've seen a version 2 interface, you've seen one version 2 interface, but you go look at somebody else's and it looks completely different. And so that ability to create a single piece of software that you can build on top of the interface is going to work the same way regardless of where you are does not really exist in the version 2 space. After version 2, we had CDA, which sort of packaged up a whole bunch of stuff into a document, which felt sort of comforting for providers because they were used to working with documents, but it's really hard for computers to work with. Trying to do decision support when you've got a collection of 50 documents, all of which reflect allergies and all of which are saying slightly different things, makes life miserable for developers who are trying to just say, is this person allergic to amoxicillin or not? You can't really get a straight answer out of a collection of CPA documents. And so in terms of the healthcare space, there is not really a similar standard out there that gives you a RESTful API, which is much more computer friendly in terms of being able to ask very specific questions, get very specific sets of data out there. FHIR is sort of the first one in that space.
Great, thank you. I think you hit that well. Does anybody have anything to add to that?
It may be an indicator of that there really isn't another truly competing standard that I think a lot of us, including myself, have built systems that translate the previous standards that Lloyd mentioned, HL7 messages, version 2 or version 3, or any of the CDA or CCDA documents. I mean, not to just speak about my own company, but we translate all of those things to FHIR resources and store them as a FHIR data model, and now that's available behind FHIR API. Well, it's not like we had another option to say, well, what other standards does everyone else know about that's API based? It really, FHIR was the first thing to come along. So it's just a natural choice to do that.
And as we've been bringing up, with that ability, it really allows us that detailed level to really fit it into the workflow, as we've hit some of these examples. That, yeah, just didn't work with a CCD summary, as we've all seen. There's another question I think I can just answer unless Helen disagrees with my answer and wants to chime in.
I might just have to comment on the last question, because I just wanted to throw out real quick the opposite, something that I've also been seeing. So when we're talking about FHIR and the FHIR standard as a condition or a requirement of recertification of health IT, that is going to fall to all the EHRs who are currently certified. Now, I have run across, and there are probably a number of particularly homegrown HIE systems, and as well as some sort of health IT vendors that actually didn't fall within the meaningful use. There are some subspecialties or non-primary specialties that actually did not require or qualify for the CMS program. And so they are using non-certified health EHRs, and so and as well as the HIEs that are homegrown or not certified health IT vendors. So it's interesting. Some of the questions I get is, do we have to do this? Not do we want to do this, because clearly there's a benefit to it for the consumer and for a clinical and all the things, for all the reasons that you've all stated here very eloquently. But the question is, do we legally have to do this? And the answer is no, you don't, unless you're a certified certified vendor, or you want to get recertified, or unless you're going to be losing Medicare, Medicaid dollars, or your state is requiring you as a condition of payment for certain services to be certified, or there is some sort of other hook as to why you are being compelled for certification through ONC. There could be players out there and stakeholders who are actually not compelled to use FHIR. So while this is not a competing standard, it's I guess I don't know if you want to call it a gap, but it's something that's looming out there, and it'll be interesting to see how that sort of shakes up, whether they get pressured into it in the industry to move in that direction, or there'll be a shakeout where providers and others will move towards FHIR-based sort of solutions.
And while we're on that subject, there was a question: what version of the Cert standards provides for the FHIR-based app or the FHIR-based API standard? I mean, it was 2015, but that didn't necessarily dictate the specific version of FHIR.
Can I take that, Tom?
Absolutely.
So down buried in the test scripts for the certification and in the regulation, it says, we strongly encourage you to use FHIR, but it didn't tell them to do it. But what the EHR vendors did is they got together and said, let's just use FHIR. And they put an implementation guide on top of FHIR, which is very important, which tightens the rules to make sure, and basically they worked together to make sure that they could release for patients the data fields that were required in that standard, that certification standard. But in the new rule that was published, the ONC rule that was published in March, that does say it requires that you use FHIR, and it also requires that more data types are exposed using FHIR.
For certified health IT, though.
Yes.
Only.
Yes,
Yeah,
very much true, Helen.
I think the specific question was about whether the regulation required the ability to embed apps into your EHR, and that is, to the best of my knowledge, not currently mandated by any of the regulations. So having the API is there. Being able to run apps within your EHR is not there, but it's something that most of the major EHRs are rolling out anyhow. To a certain extent, they're looking at the cell phone industry. And if you don't have a decent app store, you don't live very long in the marketplace. So the ability for your clients to plug in apps, to customize your interface to do the special things that they want to do is a real value add. And it also takes pressure off the EHR vendors, because they've got lots of clients who want lots and lots of things, and they can't afford to develop it all. They don't have the time to develop it all. And they can also play the Apple game of, let's let the apps do whatever they want to do, and then we'll see what's popular, and then we'll include that functionality into our software. So there is no regulatory requirement to have apps in EHRs, but the market is sort of causing that to happen anyhow, because the regulation requires that the APIs are there and the apps live on top of the APIs.
Great, thank you. And I know we're past 1 o'clock, but if it's okay with all of you, I know we started a little late. Might well have been my doing, or whatever the technology was. But if you're up for it, I'll grab a couple more of the questions that are out here, see if we can answer them. For anyone who can stay on, I see we still have a lot of folks on. Let's just hit a couple of more. I think one's pretty straightforward. Someone asked, can you explain why a provider couldn't require an app vendor to enter into a BAA in order to have access to the provider's APIs? And I think, Helen, you already hit this, that yes, of course you would, unless it's patient, the patient specifically requested this app, then you have the ability to educate them, but you can't add any other undue burden, like a BAA, correct?
Sure. I mean, yeah, you can't introduce any sort of process that is an inhibitor or would constitute information blocking. So that's very broad. So if a BAA would not be required, that's, you know, but in certain instances, you know, for example, if it was a minor, or if there were situations where there's a question as to whether the patient should have access to the information, you know, there is some decision-making process that's going on there, but you can't, in general, you can't introduce anything that is not legally required. And in the case where patients request our information, there is very little that would prevent them from getting access to their own information. And no, a BAA would not be required. Consent actually wouldn't be required. It used to be from time to time in healthcare systems, you know, you can require a patient to submit a request for their information in writing. And that somehow had morphed into systems requiring the patient to sign a consent form to release their own information to themselves. And HHS came out very clearly that you can't require a consent to be signed as a condition of releasing the information to themselves. So if there's a third party that's acting on their behalf, there's a lot of controversy around things like attorneys, you know, personal injury attorneys who are trying to get access to the information, and whether they're accessing that or requesting that as an agent of the patient or other things. So that introduces an interesting, you know, question as to whether apps would ever get used in that way, or can a patient ever assign a durable power of attorney or an agency relationship that sort of goes into verification, authentication. That could raise some issues. But again, to summarize, you can't introduce anything that is not legally required as a barrier to releasing the information to the patient.
Thank you. And I know we've gone well over, but I see one more very specific question that I think we can handle. I think Lloyd can handle pretty straightforward. It was specifically, now I'm trying to find it again, what is the status of the Da Vinci FHIR project? We're looking at clearinghouse eligibilities integration, and I wonder if this will replace it. And I'm presuming they'll say how soon.
Well, Da Vinci isn't a single project. It's sort of an umbrella that'll have a whole bunch of projects underneath it, and each of those are at different stages of development. Some of them are just starting, and some of them are getting pretty close to the publication of their initial version. The way FHIR projects generally work is we don't lock things down in the first release. We put it out, get people to implement it, see what feedback is, and then possibly make breaking changes if there are things that weren't working well before we get to the point of really locking things down. There's been lots of engagement in the payer community and reasonable engagement from the EHR community in connectathons and stuff like that. We haven't really, to my knowledge, seen any of the Da Vinci initiatives hit full production yet, where payers and EHRs are using them in anger, but we're getting pretty close to that point. Of course, within the Da Vinci space, there's regulations that mandate use of particular standards in particular places. So I'm not sure about the specific area that the commenter talked about, whether Da Vinci would replace that completely or run in parallel to it. But for a lot of actual submissions to X12 or NCPDP, there's mandates where you have to use those things. And so Da Vinci tends to work around the edges of those and work in parallel with those as opposed to replacing them completely.
Great, thank you. So I think they're not off the hook at just this moment, but get involved and maybe you can help move it further. I'll add that to your answer. I think since we're at 1:10, I think we'll have to wrap this up with answering all that we could. I'd like to thank you all again. I think it was a great panel with a greatly varied background that really gave us a great review of FHIR, and really, I think one of the keys is that we're really just getting started. And where this will go could really change healthcare. Before we wrap up, I was asked to note that there are some upcoming virtual events for HIMSS New York, July 17th. We've got a webinar on security, privacy, and compliance, unique COVID-19 legal issues. July 22nd at noon. Next Wednesday at noon, bringing the future into now, checking temperature while social distancing in the COVID-19 era. And July 24th, cybersecurity implications of telehealth. And August 3rd, redefining secure communications in a pandemic world. I think there is a screen up there showing those. But once again, thank you all. Thank you to the panelists. A great discussion.
Tom, can I throw out one last thing?
Yes.
If you have questions that have been raised by any of this and we haven't gotten to them, or they come up afterwards, a great place to raise them is on chat.phir.org. It's an open community. Anybody can sign up. There's tons of stuff there. You don't necessarily monitor it all. But if you have further questions coming out of this discussion, that's a great place to raise them. It's chat.phir.org.
Okay, thank you all. Take care.
Thank you.
Very good. Thank you.
Bye.